Well,
Yes,
can you
ma'am.
hear me well? Okay. All right. Thank you. So my lecture is about approach in emergency care. One unique thing about emergency medicine is that we don't diagnose the patient. We give what is the urgent. What we manage what is the urgent needs of the patient. This will be my first slide, the Emergency Care System Framework by the World Health Organization, or WHO. As you can see in the slides, there are 3 levels of care. First, on the scene, transport. Second is transport. Next is the facility. We oftenly give our resources to the facility and we forget about the transport, the ambulance team, and the scene or the community wherein the dispatcher or even the EMS provider can give a lot of help in managing our patient. So this is our advocacy in the Philippine College of Emergency Medicine to have this emergency care system framework works in all around the country. Okay. Now our approach as an emergency physician, our approach is very simple. We just do the ABCDE approach. A meaning airway. We check for any obstruction to movement of air to the lungs, or if the patient has trauma, we need to immobilize. We do cervical immobilization or movement restriction, and then we manage the airway. Before we proceed with B, which is breathing, we ensure that there is adequate movement of air into the lungs. So we can give oxygen, depends on the needs of the patient. Next is C, which is circulation. So we need to evaluate whether there is adequate perfusion to deliver oxygen to the organ. And we also need to check for signs of life-threatening bleeding. So at this time, we give IV fluids and we control the bleeding. Next is D, which is disability. At this point, we assess and protect the brain and spine function. So we check for the GCS score of the patient, the consciousness of the patient. We also check for the pupils and glucose of the patient. Lastly is E, exposure. So we identify all other injuries and any environmental threats, and we avoid hypothermia. So we keep the patient warm all the time. So as you can see, this is a very simple approach, which is airway, breathing, circulation, disability, and exposure. We don't move to the next letter until we provide management, or we stabilize the first letter. Okay, so we go to the main topic, which is approach to syncope. So I have 2 topics, which first is syncope, or loss of consciousness, and later on loss of consciousness, and then later on I'll be talking about approach to chest pain. Some epidem first, and definition. Syncope is defined as loss of consciousness resulting from decreased blood flow to the brain, or sudden transient loss of consciousness with a loss of postural tone. It is a common presentation in the emergency department. Approximately 3% of the ED consult are due to syncopal attack. Despite the improved understanding of risk and outcome, consensus of diagnostic approach and disposition remains elusive. So this is probably because of the varied causes of syncope. It could be cardiac in origin or non-cardiac in origin. Okay. The prevalence of syncope in the general population is approximately 19%, with only half of those having syncope consult a physician for evaluation, or goes to the ED for evaluation. For those who consult in the ED, they appear to have a higher likelihood of serious underlying cause than those presenting to other ambulatory settings. And 50% of which are admitted. Among the 50%, 80% are elderly or 65 years old and above. As far as pediatric patients are concerned, up to 15% of children experience at least 1 episode of syncope during their childhood. And in terms of mortality rate, after 1 month of the syncopal attack, it depends on the cause of syncope and comorbid condition, and it can go up nearly 5%. The risk factors for syncope includes cerebrovascular diseases, those taking cardiac medication, and those who are hypertensive, especially those who have uncontrolled hypertension. Okay. In patient with a cardiac history, 1 year after a syncopal episode, there is a 7.6% death rate has been found to be cardiac related, or those who have cardiac history. Age, the older the patient, the higher the mortality. Those who have congestive heart failure and coronary artery disease are key predictors of mortality in patients with syncope. Usually, adolescent and young adults presenting in the ED with syncopal attack have benign causes. In contrast, there is no increase of cardiovascular morbidity or mortality associated with neurally mediated, orthostatic, or medication-related syncope. I'll be talking more about the different kinds of syncope later on. So I know this is not a good slide, but I want to emphasize that there are these are the final common pathway resulting in syncope, which is from acute hypoperfusion. This could be a dysfunction from the cerebral hemisphere or the brainstem, particularly the reticular activating system. Loss of consciousness results in a loss of postural tone, with resulting syncopal episodes. So less severe derangement may result in sensation of pre-syncope or near syncope or lightheadedness. So by definition, we define syncope as transient. Therefore, the cause of central nervous system dysfunction should likewise be transient. Persistent cause of significant CNS dysfunction may result in coma or depressed consciousness. When you have hypoperfusion resulting in approximately 35% or more reduction in the cerebral blood flow, it usually produces unconsciousness. So it needs 35% or more reduction before it produces unconsciousness. And any mechanism that adversely affects the components of perfusion, like for example, cardiac output, the systemic vascular resistance, blood volume, and regional vascular resistance can cause syncope. So there are, as mentioned, there are three major classification of syncope. First is neurally or reflex mediated. Second is orthostatic hypotension mediated. Lastly are the cardiovascular mediated. Those do not fall in the major syncope classification presumably operates a different mechanism, like for example, seizure, hypoglycemia, certain toxins and metabolic derangement, hyperventilation, primary neurologic condition, and even psychiatric disorder. So they fall in the others. Okay. So the potential cause of syncope are numerous and can be categorized according to the primary mechanism. In this table, you can see systemic hypoperfusion resulting in CNS dysfunction. You could also have focal hypoperfusion of CNS structure. Lastly is CNS dysfunction with normal cerebral perfusion. Okay, the first differential diagnostic consideration is to distinguish syncope from other causes of an apparent sudden loss of consciousness, especially seizure. When a syncope is established as a working diagnosis, the life-threatening causes, primarily cardiovascular in origin, are considered first. So we treat first those cases that have life-threatening condition. So we think for the worst first before thinking of the benign causes of syncope. The principal serious causes of syncope are dysrhythmia. So you think first of dysrhythmia, probably a myocardial dysfunction, and sudden interruption of the right ventricular outflow by pulmonary embolism. We can also think of cerebrovascular diseases, principally a subarachnoid hemorrhage or SA, but we less frequently encounter it, but this one is a very serious condition. We can also think of toxic and metabolic abnormalities that may induce syncope through alteration in the blood pressure or cardiac rhythm of the patient. Structural cardiac lesions such as critical aortic stenosis can also cause sudden loss of consciousness. Most cases of syncope arises from benign causes. So the evaluation is largely focused on identifying those cases caused by serious pathology. So first, you need to take the history and physical examination of the patient, and we do 12-lead ECG at all patients presenting as syncope. Okay. In the patient's history, you need to know the setting of the syncope. Like for example, did it happen during post-micturition or during venipuncture? What is the position of the patient? Was the patient sitting or standing? Prior to episodes, what the patient is doing, and presence or absence of prodromal symptoms. Usually young, healthy, with clearly benign syncope, it requires little more than physical examination because the cause may be non-cardiac in origin, but other hematologic causes. We also do 12-lead ECG, however, the yield of which is very generally low. However, it is broadly recommended because of advances of being non-invasive and relatively inexpensive. So the first approach, if the patient presents to you to have syncopal attack, you need to do a brief history of the patient, do a quick physical examination, and get a 12-lead ECG, and then evaluate if the patient is having a structural problem on its structural heart disease or none. Okay. Symptoms can often suggest the diagnosis, although the relative weight of the history diminishes in older patients and those not able to remember clearly the events leading up to the loss of consciousness. That is why most of the time we admit elderly patient presenting at the ED with syncopal attack. The patient is asked to describe the character of the syncopal event. We need to ask for the rate of onset, position on symptoms onset, and duration and rate of recovery. And then we can also ask the witnesses for additional history. Key characteristics include, again, rate of onset, position and symptoms, and duration of recovery. Abrupt onset occurring while sitting or supine and duration of more than a few seconds are usually ascribed to serious open cardiac in origin. Additional history regarding the events preceding the syncope is very helpful, especially for those who witnessed the event. The physical examination focuses, when we do our physical examination, we need to focus on the cardiovascular and neurologic system. And signs of orthostasis should be sought in all cases in which the mechanism is suggested. So for your physical, you do your direct physical examination, you check for the vital signs, check if the patient is experiencing tachycardia or even bradycardia or having dysrhythmia. We also check for the respiratory rate and depth of the patient. Oftenly, there are cases that the patient is having hypoxia or even having hyperventilation when you do your physical examination. We also check for the blood pressure. It can lead you to probably the patient is in shock that may cause decreased cerebral perfusion or even hypovolemia or medication, or probably you can investigate a use of medication that may lead to orthostasis. Now you also need to check for the head, eyes, ears, nose, and throat. You check for tenderness and deformity to rule out any signs of trauma. You check for papillary edema, increased intracranial pressure, or any head injury. You also need to check for the breath of the patient. Probably the patient is having ketoacidosis. Okay. For the neck, you need to check for bruit and jugular venous distension. Probably the patient is having congestive heart failure or probably a cardiac tamponade or pulmonary embolism. For the lungs, you also need to check for you need to check for the breath sounds if the patient is having crackles or wheezes. This will lead us to signs of infection or left-sided heart failure from myocardial ischemia or even a pulmonary embolism. So you need to check the patient from head to toe and get a complete vital signs of the patient. One thing that you also need to check is the rectum. You need to do a DRE to rule out any gastrointestinal bleeding, or to check if the patient is having anemia. Okay. For female patient, of course, we need to check for if the patient is pregnant or not. You need to check for uterine bleeding or adnexal tenderness. Okay. Again, I'm showing this slide to give emphasis on evaluating syncope by using a 12-lead ECG. Again, it has a low yield of positivity. However, it is very cost efficient, and it can give you a lot of idea on regarding ruling in or out different diagnoses or different causes of syncope. This is just a table of what are the things that you need to do to the patient. So first, again, you need to do a 12-lead ECG to obtain screen of most of the common causes of ischemia, like for example, dysrhythmia, conduction abnormality, ischemia, or cardiomyopathy. Routine hematologic and urine studies have limited usefulness in the evaluation of syncope and are generally not indicated. So when suggested by the history and physical examination findings, you select among those in the list the laboratory diagnostics that you need for the patient. Like for example, you're thinking of congestive heart failure, you need to do a BNP, serum determination for the patient. Or if you're thinking of myocardial infarction as the cause of syncope of the patient, you need to do a cardiac biomarkers or serum. If you're thinking of, again, a congestive heart failure, a thoracic aortic dissection, you need to do a chest x-ray to the patient. So depending on the history that you got to the patient or to the witnesses and your physical examination. Of course, for female patient in the reproductive age, you always think of ectopic pregnancy as causing a hypovolemia and leading to shock that may cause the syncopal attack. So these are the summary of the tests that we can do to a patient presenting with syncope. So this test is usually performed as part of the inpatient or outpatient evaluation. So once the patient is already admitted, we can do this test. So for a patient you caught in the 12-lead ECG that are having dysrhythmia, you can request for a prolonged monitoring or Holter monitoring of the ECG. Or for those that have signs of heart failure or cardiomyopathy and valvular disease, you can request for echocardiography. For myocardial ischemia, you can do exercise and chemical stress tests, as well as cardiac and coronary artery imaging. For stroke patient, you can do carotid ultrasound. We don't usually do the head-up tilt table test. I haven't experienced doing this for those having orthostatic hypotension. And then for those having seizures, you can do an EEG. You can request for an EEG. So this is another algorithm of how to approach patient with syncope. So we focus on the syncope character, cardiac risk factors, comorbidities, and medication. If you have remember the first algorithm, so we need to do we get the history, we get a good physical examination, and get a 12-lead ECG to rule in if the cause of the syncope is cardiac in origin or not. And then we do a physical examination, focus on the complete vital signs, focus on the cardiovascular and the neurologic system. Next is the 12-lead ECG. Now, we determine if the patient's ECG clearly tells us that the cause is cardiac or not. If it's not a cardiac cause, we may do diagnostic for neurally mediated or orthostatic cause, and then we treat it appropriately. If in the ECG, we see that it may probably be the cause, the heart may be the probable cause of the syncopal attack, we can do other tests, like for example, pulmonary, a directed testing in the ED, considering the result of your history and physical examination and your 12-lead ECG. So you can do some blood workups like cardiac enzymes, your BNP, to check if it's the real cause of your syncopal attack. And then once determined, we need to diagnose and treatment. Of course, while waiting for the result, we still reassess for the ABCDE of the patient, the airway, breathing, circulation, disability, and exposure of the patient. Okay. Again, just an emphasis on the critical diagnosis to consider in syncope. So if a patient comes in to your emergency department presenting with syncope, you need to think of all of this. You need to rule out all of this. You need to think of myocardial infarction, life-threatening dysrhythmia, thoracic aortic dissection, critical aortic stenosis, hypertrophic cardiomyopathy, sepsis, ruptured ectopic pregnancy, hemorrhage, hypovolemia, and toxic metabolic derangement. So you need to think of this first before thinking of the benign cases. Okay, to do that, this is another algorithm on how to do your process in determining what's the cause of the syncopal attack. So initial assessment via your history and physical examination. Then you do a 12-lead ECG. If the ECG is abnormal, so you check the ECG. If it's if you think of ischemia, you consider it, you treat the patient as an MI or myocardial infarction. If the patient is having dysrhythmia, you request for a prolonged ECG monitoring. If it's really a dysrhythmia, then you treat the patient. Then you treat again the patient or seek special consult. If the ECG is normal, apparently normal, you may check for orthostatic changes. If there is presence of orthostatic changes, you check for the complete blood count. If the patient's count is anemic, probably the cause of your syncope is because of the anemia or hemorrhage. However, if it's normal, it can be caused by volume depletion or dehydration, or could be drug-induced. If there are no orthostatic changes or there is absence of orthostatic changes, you can think of metabolic. So you need to check for the sodium, potassium, your serum chemistry, or probably the patient is experiencing hypoglycemia or adrenal insufficiency. You can also think of focal neuro symptoms. So you need to do a cranial CT scan. So to check if the patient is experiencing stroke, TIA, or subarachnoid hemorrhage, or a complex migraine, to rule out complex migraine. You also need to think of seizure activity. So if you're considering seizure activity as the cause of the syncope, you need to ask for EEG. Okay. Next is outflow obstruction. So you need to request for pulmonary CTA echocardiogram. So if you're thinking of pulmonary embolism, dissection, valvular stenosis, or hypertrophic cardiomyopathy. You can also think of pregnancy or cardiac tamponade. So if you think there is a poor venous return, you check for beta HCG to rule in or out pregnancy, or you can do a ultrasound to rule in or out pericardial tamponade. Usually, young adult or adolescents that has no comorbids or risk factors have are the cause of their syncope is usually neurally mediated. So you can actually do a carotid sinus massage. If it's positive, probably the cause of the syncope is a carotid sinus sensitivity. But if it's negative, once you do your carotid sinus massage and it tested negative, probably the cause of your syncope is a vasovagal reflex or vasovagal reflex vasodepressor. So that's how you evaluate a patient on having a syncope. So first, you need to rule in or out cardiac, if it's a cardiac origin or not. And then you later on look for other causes if it's not cardiac in origin. So this is one good algorithm on how to approach a patient that presents with a depressed consciousness. Again, the priority is to assess the airway, breathing, and circulation of the patient. If you have a depressed consciousness, you need to check for the blood sugar, obtain the IV access. You need to maintain an SpO2 of approximately 97. Usually we do it 94 and above percent SpO2. And then we initiate the cardiac monitoring and obtain, again, a 12-lead ECG, portable X-ray, and point-of-care laboratories. If the patient is hypoglycemic, we give dextrose. If you're suspecting of opioid toxicity, we give naloxone. If the patient is malnourished, we give thiamine. Diba ito yung coma cocktail, dextrose, naloxone, thiamine. Okay? And we also have flumazenil for this. Okay? And then later on, you do your complete physical examination and neurologic examination. Again, you need to focus on your cardiovascular system and neurologic system. Okay? If the patient's condition improve, we treat and observe. If the patient's condition does not improve, despite if the blood sugar is normal, SpO2 is already controlled or stable, if ABC are already stable and the patient has not improved, we think of brainstem signs. So that's the time that we check we do cranial CT scan. So we can check already if the cause of depressed consciousness is due to a structural problem in the brain or not. Okay. After that, if the cause is structural problem on the brain, we consult a specialist and neurologist and treat cause and provide neuroprotective care, and we advise admission to the ICU. If not, if we didn't see any problem in the cranial CT scan, probably other differential diagnoses include toxins, like probably the patient took a lot of medicine, or probably seizure, or a posterior reversible encephalopathy syndrome, an infection, nutrition in origin, or even a endocrine problem like thyroid problem or steroids problem. So that's how you approach a patient having depressed consciousness. Again, it's ABCDE, check for the glucose if the patient is presenting with depressed consciousness, check for your O2 saturation, again, check for the status of the heart, get a 12-lead ECG, and then do a complete workup. At the same time, you manage your ABC if you encounter any problem with that. Once you already stabilize everything and the patient's condition does not improve, you get a clear picture of the brain. Then if the CT scan, if the brain is clear, you look for other causes of non-structural cause of depressed consciousness. Okay. Next, so this is just something to help you in determining what are the causes of depressed consciousness. So we have in mnemonics AEIOU tips. A could be caused by alcohol. E for endocrine. encephalopathy or even electrolytes. I could be hypoglycemia due to insulin. O is oxygen, probably the patient experiencing hypoxia or even an opiates overdose. And U for uremia. T, tips. T for toxin, you check for the toxin. Probably the patient is involved in trauma. You also need to check for the temperature of the patient. I is infection. And P for psychiatric could be a psychiatric problem or even porphyria. And then S for stroke, shock, subarachnoid hemorrhage, and space occupying CNS infection. So for the management of syncope, so again, it's airway, breathing, circulation, and depends on your working impression. Depending on your working impression is is how you will manage the patient. If you think it's a cardiac origin, then you manage it as or if it's an acute myocardial infarction, then you manage the patient as acute myocardial infarction. If it's a cardiac dysrhythmia, then you need to control the dysrhythmia. Okay, and then hospitalization is required for patients with unexplained shortness of breath, history of congestive heart failure, and those usually those elderly patients that experience first time of syncopal attack with uncontrolled comorbids. You need to hospitalize those patients, and those having cardiac dysrhythmia, of course, you need to hospitalize or admit those patients. For those, usually the younger generation, adolescents or children that are stable upon presentation in the emergency department and clear for any life-threatening causes of syncope, you can just observe them and send them home. As a summary, so the pathophysiology of syncope is dysfunction of both cerebral hemisphere or the brainstem or the reticular activating system, usually from acute hypoperfusion. And the reduced blood flow may be regional or cerebral vasoconstriction or systemic or hypotension. And loss of consciousness result in loss of postural tone with the resulting syncopal episode. Next is, most cases of syncope arise from a benign cause. So the history is largely focused on identifying those cases caused by serious pathology. The past medical history, particularly cardiovascular diseases and heart failure, is a key factor in determining future risk of morbidity and mortality. So again, you need to get a good history of what really happened to the patient. The physical examination of syncope focuses primarily on elements affecting the cardiovascular and neurologic system. Again, when you do your physical examination, although we do it head to toe, we really need to check for the cardiovascular and neurologic system. Next is the chief diagnostic adjunct in evaluating syncope is a 12-lead ECG. Again, after your history and thorough physical examination, get a good 12-lead ECG of the patient. Okay. And then routine hematologic chemistry, urine, and imaging studies have limited usefulness in the evaluation of syncope and are generally not indicated unless directed by a specific factor in the history of physical examination. Again, a good physical examination and history can lead you to a lot of things that may cause syncope, and after which you determine your differential diagnosis. That's the only time that you will decide what are the diagnostic procedures or laboratory workup that you will request for this patient. Lastly, disposition of syncope patient can be informed thoroughly through identification of factors suggesting increased risk of short-term mortality. If you think that the patient is not stable enough to go home, you admit the patient. If the patient is young, no comorbids, and stable upon presentation in the emergency department and all throughout the observation inside the emergency department, we can send that patient home. So that's the end of our lecture on approach to syncope. Do we have any question, or do you want me to proceed to the approach to chest pain?
Do you have any questions from our residents?
No questions.
Or do you want to proceed na lang?
George Espan. Chan. Tinatanong ko nga sa'yo, hindi ko ma-memorize eh.
Hindi ko na tinanong eh, pero sa...
Are there other questions? Are there questions po? If not, maybe we can proceed po to the next lecture po ni Dr. which is for chest pain.
In the emergency department each year with complaints of chest pain constituting 9% of the total ED visits. So basically 9% of our total ED visits are all chest pain, be it a benign case or toxic case. Again, just like syncope, we need to determine if that chest pain is caused by a life-threatening or a non-life-threatening disease. Okay. Because of the indistinct nature of the visceral pain, the differential diagnosis of chest pain is broad and includes many of the critical diagnoses in medicine and many non-emergent causes. So as you can see in this table, it is divided into critical diagnosis, emergent diagnosis, and non-emergent diagnosis. So just like in syncope, you need to think first of the critical diagnosis causes of chest pain rather than thinking of non-emergent diagnosis first. So you need to think of, it could be a acute myocardial infarction, a coronary ischemia, aortic dissection, cardiac tamponade. It could be a pulmonary embolism, a tension pneumothorax, or a esophageal rupture, rather than thinking of it could be a esophageal spasm, pneumonia, pleuritis, tumor. So you need to think of critical diagnosis first before the benign cases. Okay. In clinical evaluation of the patient, your initial question should be, should I intervene now? And what are the life-threatening possibilities in this patient? The answers are usually apparent within the first few minutes after assessment of the patient's appearance, ECG, and vital signs. So upon arrival of the emergency department that the patient is coming in because of chest pain, you should know that you already know if you need to intervene immediately or are there life-threatening possibilities that is happening to that patient. Okay, so if a patient has unilateral chest pain, respiratory distress, or even shock, and unilateral reduction or absence of breath sounds, emergent intervention with needle or tube thoracostomy is required because we're thinking of tension pneumothorax at that patient. In addition, patient with severe derangement in vital signs requires stabilizing treatment during a search for precipitating cause. Again, our approach would be A, B, C, D, E. If there is problem with A, you manage A. If there is problem with B, you manage B. If there is problem C, you manage C first before going to your diagnostic procedures. Okay. So this one is a good approach in chest pain. So upon initial assessment, a brief history of the patient, a physical examination, and even getting the vital signs of the patient. Now you ask, is there absence of breath sounds and is there shock? If there is absent breath sound in one side of the chest, you think of tension pneumothorax. If none, then you proceed with your 12-lead ECG and your chest X-ray. If there is ECG findings and right ventricular strain In a chest X-ray finding, you can think of pulmonary embolism. If ECG is clear, but you have a mediastinal air fluid in your chest X-ray, you can think of esophageal rupture. If there is ECG changes and a widened mediastinum, you could think of thoracic aortic aneurysm. Lastly, if you have ECG changes and pulmonary edema or even congestion, you can think of acute coronary syndrome. So that's how you approach the patient. So you do an initial assessment, a brief history of the patient, physical examination, try to rule out first if the patient is having tension pneumothorax or none by checking for the breath sounds and vital signs of the patient if there are signs of shock and decreased breath sounds on one side of the chest. Probably it's a tension pneumothorax. If none, you proceed with your 12-lead ECG and your chest X-ray. And try to determine if the patient is having pulmonary embolism, esophageal rupture, thoracic aortic aneurysm, or acute coronary syndrome. Now, history and your physical examination usually simultaneously happen. So when you say chest pain, you need to check for the OPQRST. O meaning onset of the pain, P for provocative and palliative measures, Q for quality of the pain, R for is there any radiation of the pain or is it centralized on the chest? Next is for severity and time of onset of the pain. So some of the significant symptoms of chest pain with associated other symptoms, like for example, if there is chest pain with indigestion or burning sensation, you can think of acute MI, coronary ischemia, esophageal rupture, unstable angina, or even coronary spasm and esophageal tear, or even cholecystitis. If chest pain is associated with syncope or near syncopal attack, you can think of pulmonary embolism or even acute MI, pericarditis, or myocarditis. If chest pain is associated with hemoptysis, you can again think of pulmonary embolism. If it's associated with nausea and vomiting, you can think of esophageal rupture, esophageal tear, or even cholecystitis. The presence of risk factors for a particular disease is primarily of value as an epidemiologic marker for the large population studies. In the emergency department, presence of risk factor in an individual patient without established disease has minimal or no effect on the clinical likelihood of a specific process. So when dealing with a patient presenting with chest pain, you need to think of the risk factor. Like for example, is the patient is hypertensive? Does the patient have diabetes? A sedentary lifestyle? Is the patient obese? Is the patient using cocaine? Or is she postmenopausal? Or had cardiac problems or any comorbids? So these are the specific findings that you may find with a variety of causes. Like, for example, when you do your physical examination of the patient, the appearance, the patient could be presenting as acute respiratory distress. You can think of the patient is having tension pneumothorax or acute MI. If the patient is presenting with diaphoresis, again, you can think of unstable angina, pulmonary embolism, esophageal tear, or even perforated peptic ulcer. When you do your vital signs, if the patient is, again, having hypotension, we think of tension pneumothorax or acute MI, or even pericarditis or myocarditis. And we also check if the patient is tachycardic, bradycardic, or hypertensive, or having fever or hypoxemia. Now, if we also of course, it's chest pain, we need to do a thorough cardiovascular examination. You need to check the significant difference of the upper extremity blood pressure, to check for aortic dissection. You also need to check for narrow pulse pressure. You need to check for murmurs, pericardial rub, or even jugular vein distension. In your pulmonary examination, you need to check if the patient is having, again, tension pneumothorax or even a simple pneumothorax by checking the breath sounds, if it's equal or not, if it's absent or present. You also need to check for subcutaneous emphysema, check if there is tension pneumothorax, esophageal rupture, a simple pneumothorax, or even a medianitis. You also need to check for valves. If it could lead you to a presentation of acute myocardial infarction, coronary ischemia, or unstable angina. Even if it's only chest pain, you also need to do your neurologic examination and abdominal, of course, your abdominal examination. Okay. Now, the two most important diagnostic mortality that you need, modality that you need to use or to do in a patient presenting with chest pain is, of course, a 12-lead ECG and a chest X-ray. ECG will help you to rule in or out acute myocardial infarction, an aortic dissection, and ischemic changes in your cardiac muscles, coronary spasm, a pulmonary embolism, and pericarditis. For chest X-ray, it can rule in or out tension pneumothorax, and in aortic dissection, a simple pneumothorax, pericarditis, esophageal rupture, and medianitis. You can also request for ABG to check if the patient is having pulmonary embolism or not. Okay, so this is just a summary of the electrocardiographic findings in ischemic chest pain. If you're considering classic myocardial infarction, you should have a finding of an ST segment elevation of more than 1 millimeter in contiguous lead or a new left bundle branch plaque. If subendocardial infarction, you need to see T-wave inversion or ST segment depression in concordant leads. For unstable angina, most often you have most often normal or non-specific changes in your 12-lead ECG. You may also see T-wave inversion on your 12-lead ECG. For pericarditis, there is a diffuse ST segment elevation and PR segment depression. So don't be confused of these findings. Most of the time, we read this as a myocardial infarction, while in fact the patient is only having a pericarditis rather than a myocardial infarction. So this is a clinical guidelines for emergency department management of chest pain of myocardial ischemic in origin. So once a cardiac in origin is determined, you can already give aspirin, nitroglycerin, and get an IV access and do some laboratory workup. If you're suspecting an ACS or acute coronary syndrome to this patient, check for the 12-lead ECG. If you have the classic signs of classic findings of a acute STEMI in the 12-lead ECG, then you can start giving heparin, IV nitroglycerin. You can also consider giving beta blockers or even doing revascularization or endorse the patient to a specialist, a cardiologist for PCI. If you didn't find any acute STEMI to the patient, you re-stratify if it's high, intermediate, or low. If it's low, then you do a provocative testing. If it's negative, you discharge. If the patient have high risk of an ACS, you check for cardiac enzymes. If there is recurrent ischemia, heart failure with ischemia, depressed LV dysfunction, or hemodynamic instability, or PCI in the last 6 months prior to in a prior CABG, we advise invasive treatment to this patient. However, if there are only intermediate risks or it's less than, after 10 minutes, the chest pain is already resolved, and the intermediate troponin, there is only an intermediate troponin elevation, we still admit the patient, but not in the ICU. Okay, so again, a complete initial evaluation, and then we treat if it's clearly a cardiac in origin. Based on your 12-lead ECG, we manage the patient accordingly. Okay, the next succeeding slides are different differential diagnosis of chest pain, their history, associated symptoms, supporting history, useful tests that we can do to this patient, and advices that we can give to this patient. So among the differentials that you can think of are on patient having chest pain are myocardial infarction, unstable angina, aortic dissection. You can also have pulmonary embolism, pneumothorax again, esophageal rupture, and pericarditis. So when dealing with patient having chest pain, you need to think of all of these differential diagnoses. Okay, so you need to think of these 7 critical conditions of diagnosis that can cause chest pain. Okay. Lastly, this is a algorithm on how you will manage patient or assess patient and then eventually manage. So again, you need to do a complete initial evaluation of the patient. You need to get a history of the patient and a complete physical examination of the patient having chest pain. Then you attach the patient to a cardiac monitor, get an IV access, and give oxygen therapy if indicated. Now you look at your 12-lead ECG, if it's cardiac in origin or not. So your differential diagnosis will be based on your history, your physical examination, and the result of your 12-lead ECG. You can think of these 5 conditions. First is aortic dissection. Next is pulmonary embolism. Next is tension pneumothorax. Fourth is esophageal rupture. Lastly is pericarditis. So we've already explained how you will diagnose or how will you rule in and out these different differential diagnoses. To manage pericarditis, probably you can do, to make sure that it's really a pericarditis, you can do an ultrasound. If there are effusion or tamponade risk, you can start with NSAIDs, corticosteroids, or you can get a cardiology consultation. If you're thinking of esophageal rupture, then you can start the patient with IV fluid resuscitation, analgesia, IV antibiotics, and early surgical consultation. So you need to consult a surgeon. For tension pneumothorax, you can do needle decompression or even tube thoracostomy. By the way, you don't need to have an X-ray prior to doing your needle decompression. If clinically the patient is, you think that the patient have tension pneumothorax, you don't need a chest X-ray to do your needle decompression, not the tube thoracostomy. Next is pulmonary embolism. If you're thinking of pulmonary embolism, you can start the patient with IV heparin or sub-Q low molecular weight heparin. And you can even start thrombolysis. Okay. Lastly, for aortic dissection, you can start the patient for beta blocker, IV antihypertensive therapy, and decrease contractility and immediate surgical consultation. And in the event that if your institution is not capable of handling of any of these cases, you need to coordinate in a appropriate hospital, not just transfer the patient to another hospital, but appropriate referral hospital. Okay. For my last slide, so how do you manage patient with chest pain? Again, we assess first your ABC, your airway, breathing and circulation, and manage that first before proceeding with any other diagnostics. So again, in chest pain, you need a 12-lead ECG to rule in and out if it's a cardiac in origin or not. And then you you manage the patient according to your working impression. So basically based on your history and your physical examination. And depends on your working impression or the final diagnosis of the patient will be your disposition. If the patient, again, if the patient is not stable, you need to admit the patient to an ICU setup. If the patient is stable, but if you're thinking there is a likelihood of patient becoming worse, you need to advise that patient to be admitted. If you think that if the cause of chest pain is just benign, after ruling it out with your diagnostic and clinical impression, you can send the patient home. Okay. So are there any questions? That will be my last slide. Thank you very much.
Thank you very much, Dr. Velasco, for your very informative lecture on the common signs and symptoms seen in the ER, in particular chest pain and syncope. So we are now entertaining questions from our residents and consultants. So do you have any questions po?
Question po, Doc.
Yeah. Hello.
Dr. Annalie po has a question. Yes, Annalie.
Doc, question lang po. For example, in a patient who has syncope and the patient during the time of the ER, the ECG is normal and the cardiac markers are all normal. Can you definitely rule out cardiac cause, or is there still a possibility of a cardiac cause if there are risk factors for a cardiac cause of syncope?
Sorry, can you repeat the question? Sorry.
Doc, in a patient who at the ER presents with syncope and the ECG and cardiac markers are normal, can you definitively rule out a cardiac cause?
Again, it's not only the diagnostic, I mean the diagnostic procedures that you're going to do or the laboratory findings that will be the basis of your disposition for the patient. Again, you need to see the patient clinically if the patient is stable, or if the patient is does the patient have comorbids, or is there a highly likelihood of the patient having cardiac problem or cardiac origin of the cause of the syncope. So it's not only the diagnostics or the laboratory findings that will be the basis of your disposition for the patient.
Okay po. Noted po. Thank you po, Doc.
Okay. I just want to answer one question here, yung onset of pain and time of onset. Onset meaning is it gradual or sudden in onset? And the time of onset, when did the chest pain started? I think yun ba yung question ni Janelle Oxon? So onset of pain tapos time of onset. I think I hope I clarified that thing.
And we also have another question po dito.
Yes, Doctora. Thank you.
Dr. Maulabnan, for non-elderly, non-DM patients, does this diagnostic approach apply even to chest pains that are not present at the time of ER consult? If not, is there some cut-off time like 24 hours without chest pain to say that this is not likely an urgent case? From Dr. Maulabnan po.
Okay. Usually in the practice of emergency medicine, if we think that the cause of the chest pain is not cardiac in origin, we usually observe the patient for 4 to 6 hours before sending home. If more than 24 hours, we usually admit that patient before more than 24 hours na i-admit na namin yan before sending home. No, I think the question is, what if the patient presented to you more than 24 hours na yung chest pain? Again, you need to, if it's young, non-diabetic patient and does not have any comorbids, and the 12-lead ECG is normal, and you really want to check if there are problems in your cardiac enzymes and eventually it's negative, then you can send the patient home.
Okay. Thank you po, Doktora. So is that all right po, Dr. Mulabnan? Okay, thank you daw po, Doktora.
I'm reading.
Any particular advice po on how we can approach patients with either syncope, chest pain, or any other symptom po, common symptom in the ER po?
Again,
we face potential COVID-19 infected patients po. Any advice?
can you repeat your last statement?
Ano po? So, any particular advice po on how we can approach patients with either syncope or chest pain, considering that we may face potential COVID-19 infected patients?
Okay. Again, during this pandemic, we treat the patient as a COVID suspect unless proven otherwise. So in our experience here at East Avenue Medical Center, so we treat the patient as COVID suspect first before we treat the patient as a clean patient. So ibig sabihin, we rule out first if the patient is clean or dirty. So kung in the case na syncopal attack and hindi namin ma-rule out na if it's COVID or not, then we treat that patient as COVID. So, meron kami we treat the patient with full PPE kasi once we rule out that it's not a COVID patient, based on signs and symptoms like the patient doesn't have acute respiratory illnesses, does not have fever, cough, colds, or general asthma malaise, we treat that patient as a normal case. So again, the approach is ABCDE pa din. And up until the time na hindi namin ma-rule out that the patient is a non-COVID case, we treat that patient as COVID. So in full PPE, in an isolation room, a different setup from the clean emergency department.
Okay, thank you so much, Doktora. Are there any questions pa po from our doctor? Bernadette? You have questions?
Wala, no question. No question, Divo.
How about the others po? Okay. If none po, Dr. Velasco, thank you so much for accepting our request po for you to lecture. It was very informative po and definitely very helpful for us residents here, both in FEU and in ITRMC. So hopefully po in the future we can still have you lecture to us po in the coming days and months po.
Okay, thank you. Thank you again for inviting me. Thank you very much.
Thank you, Doktora. So with that, we conclude our online meeting. So see you again po next Wednesday, same time po ulit, 2 p.m. So with that, thank you po for attending. And goodbye po.
Thank you po. Bye po.
Nako-record po.
Yes po, ma'am.
Okay. Thank you, everyone.
Thank you, everyone, for participating. Thank you, Dr. Velasco, again.
Thank you po.